Morning, everyone. So, thank my good friend Rajesh for having me here. And it's very heartening to see full audience. I know Rajesh has put in a lot of hard work in putting this conference together. So, I think after that first two good talks, so I'll just take you through this very important topic, sepsis biomarkers. I think my good friend Srinivas did speak briefly about the lot of advances that are happening in these biomarkers. So it can be a question for DRNB, and it is eye opener. There is so much of advances happening in this science. So the topics that I would cover are the bit of a background on what we understand with biomarkers and what we define as ideal biomarkers and how have we categorized, because there's so many biomarkers. There are 178 biomarkers. So it's important to understand how we categorize them into various groups. And we'll start with archaic ESR, which is our age-old biomarker. So we cannot ignore some of these which have evolved and charted the pathway. CRP is something which became a norm in COVID. And although it is an old biomarker, we still have used it. There is some value. So today we have to focus a little bit on procalcitonin because there are 28 randomized controlled trials until now. So which means there is so much science in procalcitonin. And today, if you have to go back home with take home message, it will be only the available one is the procalcitonin. So that is something we have to adopt. So there are newer biomarkers, like as I said, there are 178. We can discuss on biomarkers the whole day. So I just picked up some of the key things that are making some signs: pentraxin, proadrenomedulin, and strem. Srini did speak about it. It's a soluble trigger receptor expressed. So that's the receptor expressed on the myeloid cell. And there is a high mobility group, box1 protein, HMB. And there are this whole cosmos of immune markers, which Srinivas did say. So each of these cells, like you have dendritic cell, lymphocyte, monocyte, macrophage, natural killer cells, myeloid cells, all these have one biomarkers they produce, and all these are used for sort of prognostication. And there is one important aspect in this immune sort of a makeup, which is HLA-DR, where there are 13 studies that have happened, so which I'll talk very briefly on and just a summary. So as I said, there are 178 biomarkers. Why so many biomarkers? Because the pathophysiology and biology of sepsis is so complex that you have so many pathways, and every pathway will have some biomarkers. And as you would see that any sepsis, there is a huge cytokine storm. There's production of a lot of inflammatory mediators. So there are cytokine-mediated biomarkers. There are complement-mediated biomarkers. There are apoptosis-mediated biomarkers. There is inflammasome-mediated biomarkers. So it is a whole cosmos in itself. And there is coagulation related sort of a biomarkers. So, but the whole question is, what are the clinical utility? There is so much of basic science research happening in all these biomarkers, but what is the clinical utility? Because at the end of the day, we're all clinicians and we need to know what is practically relevant and clinically sort of makes sense. So for all the trainees here, there are 5 biomarkers which seems to have had clinical relevance, where sensitivity of these tests are more than 90%. And amongst these, procalcitonin and CRP still remain the most commonly available, easily available, and used one. But still, these biomarkers have inability to differentiate between the sepsis and SIRS. So these are some of the limitations. All the biomarkers that I'll be speaking have problem in differentiating between the infective and non-infective sources of inflammation that tends to happen. So we look into the categorization of these biomarkers. So this is the protein, complex protein systems, biomarkers derived from complement systems, acute proteins, and coagulation. So I'll just mark the ones which are familiar to us and which possibly can be used practically: CRP, pentraxin, and coagulation profile. And these are all there are more than this in the whole immune cells, but the ones which Srini also mentioned is tumor necrosis factor. HLA-DR is definitely making a lot of sense because it is used as a marker for prognosticating, especially the ones who will survive and who may not survive. Then there are biomarkers derived from tissues, and as you see, procalcitonin is the common one, lactate, and there are a few others from gut, endothelial cells. This we won't touch because these are biomarkers specific to the neurons. So I'm sure you have heard of neuron-specific enolase, which we use it to prognosticate hypoxic ischemic encephalopathy. So this is some sort of a categorization, how we group the biomarkers. So, but there are certain characteristics which really tell us what should be the ideal biomarker. So ideal biomarker should be easily available and should be easy to use, should be rapidly available, and they should change with the clinical spectrum of the patient. Like if sepsis is worsening, biomarkers should reflect, or if patient is improving, it should reflect. So it should be fluidic, it should be dynamic, it should be objective, and it should have good sensitivity. As I said, sensitivity more than 90%. There are only 5 biomarkers out of 178 that are studied. It should be continuous and it should not be very discrete. and subsequent infection, because in ICU we deal with ventilatory associated or other subsequent intercurrent infections, and biomarkers should reflect the subsequent infections, and they should not be fatigue component or a decay, and it should have a good correlation with the severity and mortality. And in India and worldwide, cost is important. We can't have a biomarker which is prohibitively expensive. And another important is most of these biomarkers have a problem with regards to comorbidities. If they have CKD, some biomarkers may falsely high. Like if you look at D-dimer, it goes up in various comorbidities. So we need to have a biomarker which is not dependent on certain comorbidities and certain interventions, non-antibiotic interventions. So that is also very important. So when we look at the whole pathophysiology, so you have these two important aspects, pathogen-associated molecular patterns and damage-associated molecular. And when they get affected, then this macrophage. So you have complex mechanism, but what we need to understand is macrophage activation is important as a protective element in sepsis. So macrophage gets activated and the toll-like receptor gets exposed. So any injury to the tissues causes release of procalcitonin. And when the macrophage gets activated and expresses this, they produce IL-6. And Srini has already said IL-6 is important. We use this in COVID to determine whether we need to give tocilizumab. Why IL-6 is? IL-6 is what facilitates the production of CRP by the liver. So that is why it becomes very important. The IL-6 and CRP are interlinked. And if you recall in COVID, we used to do CRP levels, we used to do IL-6 levels because these both are interrelated. But as you said, it is produced by liver. So if you have a liver dysfunction, obviously you cannot depend on CRP. So those are some of the limitations of certain biomarkers. And Srinivas did mention about this beautiful graph. This is very important in exam. If they ask the questions, please put this graph, which gives you a conceptual understanding. In sepsis, what we see in the initial phase is this acute response, and studies have shown 10% of deaths happen during this phase. But 30%, if you take a sepsis mortality as 40 to 50%, 40% of the deaths happen in the post-sepsis phase, which Srinivas was reflecting upon. So it's a compensatory anti-inflammatory response syndrome, and the immune paralysis happens, and deaths happen, 30% of the deaths that happen in this post-sepsis phase. That's why a lot of biomarkers which we are trying to investigate to see whether we can identify a biomarker which can prognosticate whether in the post-sepsis stage. Why we say this? We give antibiotics, patients get better, but we see the organ dysfunction never improves. And that is what we are here to understand. And HLA-DR seems to be giving us answers or signals, and there are good 13 studies which have shown some relevance of HLA-DR. So we'll start with one by one very quickly. ESR. So ESR is a very simple, age-old, archaic tool. So for all the trainees, just the speed at which the erythrocytes sort of sediments, and this distance increases, that is the erythrocyte sedimentation rate in 1 hour. So the rate at which the whole sedimentation happens. And this is dependent on the biomarker fibrinogen, which influences the ESR. The advantages is it's easy and you don't need skill levels. You just collect the blood, keep it for 1 hour. The rate at which erythrocyte sediment will give you that erythrocyte sedimentation rate, and there's no cost. But the disadvantages is it is non-specific. It varies with age, varies with temperature. And like any biomarker, you'll keep hearing this. They increase in non-infectious like cancers. You can have high ESR, multiple myeloma specifically have high ESR, inflammatory conditions. And as I said, CKD, ESR can be high. So these are all the caveats of these ESR, and they're not very specific. So CRP, we have used this very often. So as you said, when there is an inflammation, IL-6 get released and the liver releases CRP and fibrinogen. So the CRP increases acutely. 4 hours, the graph increases, it doubles in 8 hours, reaches the peak in 36 to 40 hours. Half-life is around 19 hours. Advantage is it can be used as a good screening for infection because it rises fairly acutely. And it shows response to antibiotics, whether post-antibiotics, if the CRP levels are coming down, you know that patient is responding and you have chosen the right antibiotic and you address the source, so on and so forth. It is easy and the cost is less. Sensitivity ranges somewhere from 68 to 92%. Specificity is pretty low, 40 to 67%. So these are some of the salient aspects of CRP. The disadvantages is, as I said, it's non-specific and it is unreliable in the liver dysfunction because it is produced by the liver, facilitated by IL-6 levels, and it cannot discriminate between infectious and non-infectious causes. And CRP also is notoriously non-specific. It increases in trauma, burns, post-surgical patients, inflammatory conditions, even in acute MI or ACS, which commonly we see myocardial dysfunction, CRP can go up. So some of the clinical studies, most studies with CRP interestingly has been done in neonates and pediatric group, and they've shown that CRP less than 10 in neonates, one could consider stopping antibiotics. And this was a Brazilian study like procalcitonin. They showed that CRP usage did curtail their antibiotic usage by 1 day, 6 versus 7 days. Most of the studies with CRP are done in pneumonia, where the reasonable conclusion was made if it is less than 20. And this we used in COVID. If CRP levels were low, we did not really get alarmed. But when it was going up, that's when we started thinking about tocilizumab and so on and so forth. If it is more than 100, one has to continue antibiotics. Like CRP, if you look at the clinical studies, most of it is done in pneumonia, and they are put at these numbers. Less than 20, you can safely consider discontinuing antibiotics. If it's more than 100, you may have to continue antibiotics. So that is all we have at this point of time on the clinical relevance in ICU. In COVID, of course, we saw a lot of utility of CRP. So pentraxin, it is very similar to CRP, and pentraxin is not produced by liver, it is produced by all these inflammatory cells. And increase in pentraxin is associated with severity of sepsis. The value of pentraxin came from the Albios trial, because Albios trial, which was a sepsis trial where they used albumin, they looked at 958 patients where they saw the utility of pentraxin, and it had a good correlation with the severity of sepsis, and it had a correlation with organ dysfunction, and it had a correlation with mortality. That's where this came into highlight, but it is not routinely used. Pentraxin is very similar to CRP. So we'll talk a little on procalcitonin, because this is one sort of a tool that is practically useful, and we need to have reasonable sort of a clarity on where we stand. As I said, there are around 26 to 28 randomized controlled trials. Even just 1 week back, there was a meta-analysis that came. So is procalcitonin helpful in diagnosing infection? The answer is no, because where procalcitonin is useful is to stop or de-escalate antibiotics. Why? Because day one procalcitonin is considered as non-contributory, and it really doesn't tell you whether there is prior infections or whether it's non-infectious. And if you have a focal abscess or if you have a focal infection of any sort, sometimes procalcitonin can be low, and there is a lag time between procalcitonin reaching the peak time. 24 to 48 hours is the lag time. And these are all the references for you. There are 7 studies which are said for diagnosing the sepsis, procalcitonin may fall short. So it is not a test that you would do to start antibiotics. It is a test to de-escalate and stop antibiotics if the levels are coming down. And I'll talk only about 2 randomized control trials and 2 meta-analyses, the latest ones, so that all the trainees should have some clarity on the clinical science, clinical studies that have happened with Procal. So why we need Procal? Because we need to differentiate whether there is non-infectious causes of fever or the infectious causes, because in ICU there is a huge overlap and we start giving antibiotics for everyone. So we need to be clearly, I use procalcitonin to convince my oncologist or my other doctors to say we are going to stop antibiotics, or liver transplant, because transplant and oncology is one area where we are seeing increasing use of antibiotics, and this is mainly to convince them that we have to stop antibiotics. So this is a trial that every trainee should know, the ProRata trial that came from the French group. So this was a trial where 67% were mechanically ventilated, 50% had community acquired, and 50% had hospital acquired infections, done in 621 ICUs. And what you see in this study, which is a randomized control, is the antibiotic free days were more in procalcitonin, which means they could stop antibiotics, and they found in the group where the antibiotics was stopped, the outcomes were better. So that's an important message, that usage of antibiotics in fact can worsen outcome or worsen mortality. This was shown in the progress trial, which I'll talk. That is the recent study which came in 2020. So all the trainees go home with a message that you continue to use antibiotics. In fact, you can cause more deaths. By stopping antibiotics where it is not needed, you can save more lives, was the message. Then after this was a Swiss meta-analysis that came. 11 randomized controlled trials, 2,252 patients. Even here they showed when procalcitonin was used to stop or de-escalate antibiotics, mortality was 21 as compared to 23.7, and the antibiotic duration also was significantly less, 9.3 days versus 10.4. That was also significant. So both this meta-analysis and this trial really tell you that procalcitonin has to be contemplated where you do not believe there is an infection, to stop, to improve the outcomes. And this was re-emphasized by the most recent study, which came in, it's called a progress trial by the Greek authors. It came in 2020. This also showed a very strong signals endorsing the ProRata and this meta-analysis. So what this showed was 266 patients, 125 were in the PCT group, 131. They looked at infection-related adverse events at day 180, and as you see, it was significantly less in the Procal group as compared to the standard group. And this is very interesting, the mortality. That's what I'm re-emphasizing, that continuing antibiotics can in fact worsen mortality. As you see here, it was 15.2 versus 28.2%, which means by using Procal to stop or de-escalate antibiotics saved lives. And even the duration of antibiotics was 5 days versus 10 days, and the cost also significantly came down. So this is a 2020 RCT which re-emphasizes the utility of procalcitonin, that as intensivists, as champions of antibiotic stewardship, I think one needs to really use this tool at least to convince your other core specialties if they are indiscriminately using antibiotics. And the conclusions was, in sepsis, procalcitonin guidance reduces the infection-related adverse events and reduces the 28-day mortality. So if you are not convinced with this, the most recent meta-analysis, which I'm sure you would have seen in some of the WhatsApp groups. So this came in just 1 week ago, 2023, by the Hungarian groups. This is the largest meta-analysis so far. For all the trainees, you can keep this in mind. So this was 26 randomized. So there are 26 RCTs that have happened in procalcitonin, 9,048 patients. Even this meta-analysis showed the 28-day mortality significantly came down when procalcitonin was used to de-escalate or stop antibiotics, and duration of antibiotics was lessened by 1.79 days. All these were statistically significant if you look at confidence interval, but the recurrent infections tended to increase in where procalcitonin was used, and all these were statistically significant. But when they looked at secondary infections and ICU and hospital length of stay, there was no difference between the PCT and the control group. So you have ample evidence. So you have 26 RCTs, the progress trial, the prorata trial. I think these are compelling enough for us to subscribe that procalcitonin has to be used at least where you have to convince yourself or other specialties that we don't need to continue indiscriminate usage of antibiotics. So that's about Procal. Just very brief overview because there's a lot of trials. So I just wanted to talk about 2 recent trials and meta-analysis. So proadrenomedulin, so this is another sort of a biomarker that predominantly comes from an injured tissue, and the main role of proadrenomedulin is vasodilatation. It has some antimicrobial and anti-inflammatory effect. So proadrenomedulin is produced from the brain, it can be produced from the heart and lungs, and it is produced from the fat tissue also, and it is produced from the kidney. So these are the sites from where this biomarker proadrenomedulin comes. So the clinical utility, it was found to be higher in sepsis than in SIRS. So it is a tool which possibly we can think of for the future to discriminate between SIRS and sepsis. And especially it was useful in febrile neutropenia to differentiate between the SIRS and the febrile neutropenic sepsis patients, because it has some discriminatory ability to differentiate between SIRS and sepsis. And unlike procalcitonin, even in a focal abscess or a focal infection, proadrenomedulin goes up, and it was found to be superior to procalcitonin. So this is I think this is something to watch out for. And it had a good correlation with mortality in pneumonia patients. So the disadvantages is the cost, and I don't know its availability in India at this point of time, whether it's freely available. Like any other biomarker, some comorbids increase, like you saw CKD, ESR goes up. So in CRP, does not go up in liver. So this goes up in heart failure. And this is again a limitation of this biomarker. And STREM, which is soluble triggering receptor expressed on myeloid cell. So this tends to go up in infections and even in candida infections. Sensitivity was found to be 82%, specificity was 86%. And admission STREM had a good correlation with increase in mortality, and it had a good sort of a correlation with rapid decrease, improves the outcome, and it tends to go up even in heart attack patients or MI patients. So these are some of the disadvantages of STREM, and the assay method that is used to determine STREM determines its accuracy. So these are some of the highlights of STREM. Presepsin, I think Srini did speak briefly. This is like CRP goes up within 4 hours. Presepsin is much ahead. It goes up within 2 hours, 13 kDa protein. Within 2 hours after onset of infection, this level goes up. Half-life is 4 to 5 hours. It is not affected by burns or other inflammatory conditions and even neutropenia. Sensitivity was 87.8 and specificity was 81. Again, not a great sensitivity because for a biomarker, you need sensitivity more than 90%. Utility, again, like so the prognostic value was determined from the Albios trial, and disadvantages, it is non-specific, and like any other biomarker, it tends to go up in alcoholic hepatitis or any liver condition. It tends to reflect very poorly. and it can go up in temperature or psoriasis patients. So no biomarker is not influenced by other comorbids. Most biomarkers you see are influenced by concomitant other clinical conditions. The other big disadvantage is the studies have shown it does not go up in UTI, which is again a major limitation of presepsin, because UTI is something which we commonly see. If it does not go up, it's not of much relevance. So very quickly on HMGB, which is a high mobility group box 1 protein, as you see pictorially, they are released from the lysosomes and from the nucleus, goes up in 8 to 12 hours, reaches the peak and plateaus in 18 to 30 hours. And day 3 levels discriminates between survivors and non-survivors. Sensitivity is very poor, 66, and specificity is 67%. Disadvantages, non-specific, again goes up in all the other inflammatory conditions and goes up in cancer. So I just have 1 minute. I'll just cover this immune markers. So as I said, there are a whole lot of cosmos of immune cells which produce various biomarkers. So, and what really happens in post-sepsis is there is sort of a cell fatigue that happens, and there is increased apoptosis, and basically all cells get fatigued. They have inability to clear the bacteria, natural killer cells come down, and there is a lot of expression of myeloid depressor suppressor cells. And dendritic cells is something which expresses the HLA-DR. I'll just take 1 minute to explain this HLA-DR. So this HLA-DR really prognosticates. So if you have a good expression of HLA-DR by the dendritic cells, like if you see in this study, more than 8,000, the mortality was 10%. But if your HLA-DR expression is less than 8,000, they saw that mortality was 65. So it is a prognostic tool which tells us which are your sepsis patients which survive or which do not survive. And these are the clinical studies with HLA-DR. There are 13 clinical studies already happening with HLA-DR. Just I'll very quickly take you that IL-7 and IL-15 are important biomarkers which are helpful in prognostication, because if you have high levels of IL-7 or high levels of IL-15, they are found to be protective in sepsis. And for all the trainees, just remember IL-7 increases the production of interferon gamma that leads to activated macrophages, and that is very protective. And same thing with IL-15, it leads to increase in the activated macrophages which binds to all these 8 cells and they produce interferon gamma. So IL-7, IL-15, increase in the production of interferon gamma, activated macrophages, these are protective, and there's a lot of studies happening with these markers to prognosticate sepsis. So the future is all the omics. So there is genomics, transcriptomics, and there is this proteomics. All these are PCR based, and there is single nucleotide polymorphisms they look at, and metabolomics, basically to looking at the metabolic profile of the patients to determine who will survive and who will not. So this is the future of sepsis. So the take home message, there are 178 biomarkers due to complex pathophysiological sort of a process involved in sepsis, but there are only 5 biomarkers which achieve sensitivity of more than 90%. So even to date, PCT and CRP are most commonly used and still relevant. The newer biomarkers that hold promise is all these immune biomarkers, and I think there's a whole lot of science that is happening, and we will see a lot of monoclonals which will come into play to address all this. And pro-adrenomedulin STREM seems to have some promise. HMGB and presepsin also, there is some sort of a hope. But the future of sepsis really lies in all this genomics, proteomics, transcriptomics, and metabolics, which are all using PCR-based sort of analysis. They even do a genetic sort of a imprints and see, because we have got new generation sequencing, which we used in COVID. So these are the tools that we have available, which gives you a genetic makeup to say who are the sepsis patients who do well. Like Srinivas said about phenotype, we are talking about phenotypes, and then we are talking about genotypes to determine which sepsis patients do well, which sepsis patients do not do well. Despite all your best efforts, which are the patients who are going to die. This is the future. Again, re-emphasizing what Srinivas said about the future concepts in sepsis. So thank you one and all.